So this was designed to just talk through some issues around COVID and the booster shot, and particularly also with it, the flu shot that we hope that most of our colleagues will be taking up over the course of the next couple of weeks within our LLR health economy. Now, interestingly, COVID is, I'm no longer going to use words like a wave and things like that because there are no longer waves of COVID that are going across the system. We've got a naturally high level of transmission of the virus, as you'd expect with any respiratory-borne virus that's new and that's been in the system now for 3 years. We have developed significant amount of immunity within our UK population against COVID. And we also have developed quite a lot of data around the efficacy of that immunity from vaccinations. And more recently, there's been 2 significant papers which have looked at UK-based immunity and the third booster shot in terms of the efficacy for reductions in hospital admissions and ITU admissions and falling mortality. And a big data set that's come out of the US looking at very much a similar thing. And what they've clearly identified is that if you were to take your booster immunity 6 months after you've had your full shot, then you are 3 times less likely to go into hospital and be admitted into ITU, and 14 times less likely to be have a mortality associated with COVID than if you just had the full 2-shot program. Right. So what that tells us is that the booster itself is significant in enhancing immunity against the Omicron strain and the original strain. But now that we know that within the Omicron strain, there are 2 particular strains, BA4 and BA5, and BA5.6 now as the newer omnivalent strain of Omicron, we know that it is more infectious, but probably less toxic. Well, I don't think we have to use the word probably. I think we know for a fact that it is less toxic. And it's behaving very much like other respiratory viruses do that have evolved in the form of coronavirus that have stayed within our viral market, as I call it. Now, so having said that, it is now undoubtedly true that if you want to continue to have the greatest protection against COVID, then the 4th booster is 6 months after you've had your 3rd is probably going to do that, right? We will wait to see the effect of that in due course. But certainly for 5 particular groups of people, it would appear to be that the booster is necessary 6 months after the 3rd. And that is the group that's aged over 70, have multiple comorbidities, more than 3 comorbid conditions, the group that are severely immunocompromised, those who are on a transplant organ register, and those who have very chronic neurological-based conditions, which includes severe learning disability. So those 5 groups are therefore going to be targeted in particular against the COVID booster, the 4th booster program. And at the same time, this has been extended to NHS frontline staff who work and have the potential of cross-infecting that particular group of patients. So everything that I'm hoping will resonate with all of you, and why the 4th booster is probably necessary if you've had the 3rd, and why 6 months after the 3rd this is going to be particularly important going into this particular winter, which we're going to be hit with. And we're already seeing that. We're seeing early flu cases in hospital, which we don't normally see around mid-October. We've seen a 200% increase in the numbers in flu within the hospital. COVID numbers have increased within our acute hospital sites at UHL from a baseline of around 60 patients in late September to now something around 130 patients and with almost about 15 patients a day coming in with COVID-related illness. However, having said that, only 1 in 6 of patients who are COVID positive in acute hospitals right now are actually struggling with COVID symptoms. And but most of them are nosocomial or have a coincidental finding of COVID positivity in their serum, in their sputum. So I hope I've sort of tried to put that into perspective. Are there any questions? I'm happy to take it.
So you say the fourth booster is 6 months after the third booster.
Yeah.
So for those of us that don't fit the criteria for patients, obviously staff, I had my third one last year. So is me having this next one, is that still going to be okay? Will I have still enough immunity for the fourth one to be as effective, even though it's more than 6 months?
Yes. So sorry. What I should have meant to say was that it's most effective. It starts to become effective from 6 months following the last booster. So you shouldn't be taking it within the 6 months following that.
Okay.
Right. So
yes,
absolutely, the longer you delay the booster dose, the longer it takes for you post the booster dose to get fully protected. So generally, because you're almost a year out, you would need a full 2 weeks after the booster dose for you to be fully protected.
Okay.
So yeah, go ahead, take it, but it would be 2 weeks before you got the full protection from the fourth dose.
Okay. Thank you. Again this year. What vaccinations are available, and what are the risk profiles associated with them for the COVID vaccination? So
currently the only 2 vaccinations that are available are the mRNA vaccines that are covering the bivalent vaccine module that we have. We were originally at LPT only giving the Moderna vaccine, but I gather there is a move to also give the Pfizer. That we're going to get a Pfizer batch coming soon. Sarah, you can.
Yeah, we've had Pfizer bivalent since the end of September now.
Right. Okay.
And no Moderna available. I guess for Lynn, it's the question around people on the, is it okay to say Lynn, on the allergy pathway?
I didn't know there was a pathway, but yes.
Yeah, so people who had AstraZeneca previously, AstraZeneca is no longer available to us. So there is a separate pathway through UHL for those who cannot have Moderna or Pfizer vaccinations.
A little bit similar actually to Lynn's, but basically what it is, I had 2 AstraZeneca ones, the first 2 ones. The first time I was very bad with severe headache. So the second time I was like really dreading it, because these headaches were like, whoa, they were like really, really, really bad. And the second time I was fine. So they did say you might have had a blood clot when I went the second time, if your headache was that severe. But I don't know why she said that. So second time I was fine. And the third one I had the Moderna. And touch wood, I was fine with that. So I have had a text to say you're due to have your booster again. So am I allowed to just have the Moderna if I've been all right with that, or would I have to have a Pfizer?
Yes. No, you can have any one of the mRNA vaccine boosters.
Okay.
And trust me, and I say this because I've had every single one of them. So I've had Pfizer, I've had 2 of Pfizer, I've had AZ, I've had Moderna, and I've had Pfizer again.
Yeah.
Right?
Yeah, sometimes I just have allergic reactions sometimes. Now, the same goes with the flu jab. I really, really do not have the flu jab because one year I just did not cope very well with after that for about 3-4 months. So that is one I'm really like still hesitant, but I do encourage the whole family to have one. Like my daughter who's asthmatic and my husband started having one now as well. So since COVID, I do encourage. But I personally do not have the flu jab. I'm really scared to have the flu jab because it gave me that bad reaction one year. But if I had
so the flu jab is an adenoviral jab, which is similar to the AZ jab. right? And so your first reaction to the AZ jab is pretty much what you were reacting to in the same way. And I doubt it was a blood clot, because a cavernous sinus thrombosis is what they're talking about, which is when it first came out, that was within months. That's what everybody was talking about. It would be unlikely. I mean, it's possible in the realm of things, but it's unlikely. And it only hit about 1 in 580,000 people. So we're talking 2 in a million, right? People who got a cavernous sinus thrombosis. But we did see headaches as a very common side effect of getting a booster, of getting a shot. Now, I mean, I think if you are already taking shots and you know that you're living with them, an adenoviral flu is much less potent in terms of the concentrations that we give compared to the AZ concentration we gave for the virus. So there is one gleaming bit of hope there. I can't, I'm not saying to you don't take it. I think you should take the flu, because this year particularly we are going to struggle as a healthcare economy if people don't. Normally the flu uptake is around 50%, right, in the community. If we can up that to something like 65%, that the skew of the curve in terms of the bed requirements shifts considerably for us in our favor. So give it some thought, please. Flu can be as nasty as COVID in many ways for a lot of people. So
currently got patients on the ward with COVID, but what are the organisation's plans for roving teams again for flu, and would you do it for the flu vaccination as well as COVID, for our inpatients?
Yeah, shall I answer that one?
please, yeah.
Yeah. Okay. So you probably aware that for several months, including all of last winter, we've had a roving COVID vaccination programme. I'm saying that slightly loosely in that it's been a one-man band. So it's a member of staff on the bank who goes out, and in response to requests and consent received, numbers, we've been out to quite a lot of the inpatient areas, particularly at the Bradgate unit where the patients are in a little bit longer, and to some community hospitals. So as soon as we've got a request, we have sourced a roving vaccinator and got everything planned and got out there. And that continues. So currently we are roving for patients with the bivalent Pfizer vaccine. So that's available. So for example, tomorrow, the roving vaccinator is at the Evington Centre. So that will continue, and there is a SOP that identifies what you need to do in order to progress that, and as soon as we pick that up, we will be back in touch, but it isn't an immediate fix within a day or two.
No, and that's been my experience when I have made referrals. The patients have then been discharged due to a number of factors.
Yeah.
So the patient, or not enough patients, or the availability of the vaccine, the availability of the member of staff, all these factors are in there. So it's basically carry on as we were before.
Yes. So what we are doing now, because we are in the position where we're giving the COVID booster to staff, is where we go to an inpatient ward to vaccinate 2 patients. We will say, I've got 3 doses left in this vial. So any staff who haven't had the COVID jab, who'd like to have the COVID jab, consent and roll up your sleeves. So we are actively doing that to reduce wastage of a precious resource. So we are doing that, and we will do that as much as we can in terms of practical and safe. We do recognise that the community hospital wards, the turnover is a lot quicker. So by the time we receive it, we get all the information back and we plan a vaccinator. That patient's gone home, and that's just that's down to good bed management. And if we had plenty of staff, we would be able to come out a lot more quickly, but like everywhere, staffing is a very scarce resource. In terms of the flu jab, so if I talk about patients and flu, what we've done is we've used a process used previously within the the mental health wards, whereby they were actively giving any patient who fit the criteria to have their flu jab. There's still some, I would say there's still some still ongoing work around recording it on System 1 to enable the GP to see that that patient has had their flu jab as an inpatient. But I've seen further narrative again today to say that should not delay a patient having their flu jab, because we will include it in the discharge letter, we will include it in the drug summary, and we will record it on System 1. The risk is that it doesn't sit within the vaccination list that the GP might look at. So it's relying on the GP looking at the discharge summary and the patient and their relatives being able to say, actually, they had their flu jab while on the ward. So that's just still for a little bit more discussion. That would be then prescribed onto Wellski, and the prescription would be picked up by the pharmacist and come out to the ward and given by the ward RN.
Okay, so just a point that you made, I had a lady the other day who I clerked and developed respiratory symptoms. Anyway, it turned out she was COVID positive, but when I said, was she vaccinated, she said yes, and that she'd had her 4th dose. But when I looked on the system in the COVID section, and her GP's on System 1, when I looked there, it only had the 2 doses, her initial doses of the COVID vaccine. It didn't have the 3rd and 4th. So it sounds like it must be a system-wide issue and not just for GPs, but for those, yes, a two-way process that we weren't able to. But fortunately, she knew exactly what had gone on with herself, thank God, and was able to say, yes, I had my 4th vaccine, and she had it about 4 weeks ago, but she's ended up with COVID and feeling rotten with it as well.
Yeah, I agree, Lynn. It's a difficult process because all COVID vaccinations are recorded on NIVs everywhere except in GP surgeries. So if you had a patient, you had a query, we could look on NIVs to see what we could see, but we wouldn't be able to see what they'd had within a GP surgery, because not all GP surgeries are using NIVs. Some are just using System 1. So you need to use that process of medicines reconciliation, asking the patient and asking their relatives, as well as checking any records that you've got.